Hello, my name is Sarah Maines. I am the director of the Liver Cancers Program at Global Liver Institute. Thank you for being here with us today during the October is for Livers campaign. GLI, we are the world's largest patient population, the largest liver patient organization, bringing together more than 200 organizations across our councils, campaigns, and events to continue to advance liver health as public health to both prevent liver disease and scale optimal approaches to improving the lives of individuals and families who are impacted by liver disease and liver cancers. Our hashtag October is for Livers campaign is the first and only global program that's dedicated to public awareness, policy, and clinical practice needs that help prevent and manage liver cancer while educating and empowering those who are impacted by liver cancer. Our campaign will not only push boundaries in equity and advocacy, but also look at innovation by connecting diverse communities around the world to collectively tackle liver cancer. The whole is greater than the sum of its parts, and this couldn't be more accurate to describe the work that we're doing, the value that we bring, and how we drive a better future to liver health through our global approach. Today's conversation, we are so happy and proud to be joined by Dr. Arpan Patel on palliative care and HCC management. Dr. Patel is the Assistant Professor of Medicine at the David Geffen School of Medicine at UCLA and is the staff hepatologist at the VA Greater Los Angeles Healthcare System. Dr. Patel, thank you so much for being here and joining us today. Welcome.
Thank you, Ms. Maines. It's such a delight to be talking to you all today about this topic. Even just hearing about the amazing focus that GLI has on improving the lives of patients and families resonates so deeply with me, and I think is an important way that we can start bringing up this topic about palliative care. So I hope by the end of the talk, you agree with me that this is an important focus that we should consider for everyone affected by liver disease.
Thank you.
Here are a few of my disclosures, which are research grants that I'm currently working on. So I wanted to go through some of the aspects of my talk just to give a nice roadmap. So first, I wanted to describe some of the gaps that are experienced by patients and individuals with HCC and their caregivers with regards to palliative care. And this gives us a nice opportunity to talk about some definitions and an overview of what that concept is of palliative care. And then in the second part of the talk, I wanted to discuss strategies that not only clinicians, but that we can all use for implementing principles of palliative care in the care of patients with HCC and how we can overcome barriers and utilize resources that currently exist. I enjoy usually bringing up patient cases because I think that really contextualizes a lot of the situations we find ourselves in. With not just with regards to palliative care, but many important topics. And so I treat patients at the West Los Angeles VA hospital. And so this is a patient that I treated recently who is a 55-year-old veteran who had decompensated liver disease from fatty liver. And he had indications that his liver was not functioning well. But in addition to that, had a finding of 5 liver tumors on his MRI. And for those of you who may know this classification, his stage of classification for liver cancer was stage B. When I start having these conversations with patients, I'm very sensitive to the types of topics they bring up. In addition to talking about things like liver transplant and what they should expect from a transplant evaluation, I noticed that in this case, the patient and his family brought up a few other questions. And some of these might be things that you have on your mind or that the clinicians hear. So these questions are, how long do you think I have, doc? Me and my family need to know. What are the side effects for each of the treatments? For transplant, do you think my wife will have to take off work? I think these are very reasonable discussion points. And I think that many times these are things that we are all trying to figure out as they go by. But, truthfully, some of these conversations are actually a lot more complicated. And these are answers that patients and families may want to actually know about before they make a decision about many of the types of treatments they're getting. And honestly, sometimes they're very difficult to answer. So for me, I tried my best to answer them, but was noticing that there was a lot of uncertainty in the way that I was communicating that, and also just general uncertainty about whether or not we have to continue to revisit a lot of these conversations. So I'm fortunate at the VA that I have a lot of resources for handling these situations. And in my case, I actually asked about considering a specialty palliative care consult because what I was sensing was that there were not just questions about someone's disease, but there were concerns about things like prognosis and uncertainty, about quality of life, and about the impact that this type of illness would have on caregivers. And to me, these are all palliative care needs. And so that was the reason why I got that team involved. And I'm hoping by the end of the talk, we start to reconceptualize that these are issues that are just as important, if not important, than actually treating the tumor. I think it's helpful to reframe that, while we are dealing with a condition that we want people to have high access to the best treatments available, unfortunately, where we are now is still not where we want to be. And death is still very likely for patients with hepatocellular carcinoma. From the most recent statistics we have, we still know that 5-year survival is just around 1 in 5 individuals. And much of this is due to the fact that patients are often late stage in their diagnoses, more so than we'd like them to be. But I think this is important to note that, whether or not a patient is coming to us wanting the most treatments, there is this veneer of thinking that there might not be a good outcome to all of the treatments that happen for patients. And that's something that we all have to keep in mind. So understanding that patients with liver cancer have a high risk of mortality, we do a lot as clinicians, patients, and family members to try our best to mitigate the disease and treat it. But I think sometimes what we don't do is really think of things like advanced liver disease and HCC, not just as individual conditions, but what's called a serious illness. So this is a term that's beginning to gain some traction because what we understand about conditions like HCC that are serious illnesses is that they don't just have a high risk of mortality, but they have a lot of other spiraling effects. We know that patients who experience serious illness, their conditions often strain their caregivers. We know that their illnesses often impact their own quality of life. And it's important for us to conceptualize HCC as this because what we often do as clinicians and health systems is focus on this mortality, but what we may not be actually doing is focusing on some of these other issues. And when it comes down to making really difficult decisions, sometimes patients and families might actually prioritize one of these things more than others, particularly when their condition gets hard to treat or when there's a lot of uncertainty about what's going on. So I just want to use this slide as an opportunity to say that sometimes cure or not cure is not the only priority. And we have to keep that in mind, particularly when people are forced to make really difficult decisions. I wanted to spend a few slides talking about the fact that we are often missing the mark when it comes to some of these other dimensions of care that I mentioned. There's now a pretty substantial amount of emerging literature showing some gaps in quality of life and caregiver support for patients with liver cancer. We know that patients with HCC have significant symptomatic disturbances that range from pain, sleep, fatigue, and appetite issues. We also know they have a high rate of being diagnosed with mental health issues like depression and anxiety, often much higher than the average population and much higher than other chronic illnesses. In addition to patients experiencing some of these gaps, we know that caregivers themselves experience significant problems, having similar problems with depression, mental health issues, and just the strain and support and strain that this could have on themselves and their finances. We know that in addition to some gaps in the patient and caregiver quality of life, that at the end of life, things are often also not fully perfect. We know that the hospice utilization for patients is lower than many cancers, and patients only stay on average 18 days. Whereas if you think about what hospice is, it's supposed to be a form of medical care offered for people with a 6-month prognosis. And if people are being referred late, if people are being referred only with 18 days, it's likely that they're being referred quite late. So understanding now that we are having a lot of gaps when it comes to addressing quality of life issues, caregiver issues, and issues at the end of life, I wanted to reframe us into thinking about what palliative care is and how this can fit into the puzzle. So there's an organization called the International Association for Hospice and Palliative Care that has defined palliative care as active holistic care of individuals with serious health-related suffering due to severe illness, and especially those near the end of life. The goal of palliative care is to improve the quality of life of patients, their families, and their caregivers. And I think this is important to highlight because I often hear some different perceptions from patients and families about what palliative care is. Patients and families might think palliative care means hospice, means end-of-life care. They might think palliative care just means a specific service that's being brought in to take care of patients. But I wanted to reorient us into thinking that it's not just a specific doctor or person seeing patients. It's not just hospice. It's an approach to care in which we are not only just thinking about life or death, but we're thinking about some of these other dimensions of care, like quality of life, like caregiver burden. So it might be helpful to think about why we have such traditional views of palliative care. And this comes from what we knew palliative care was in the 1960s and 60s before the hospice movement. We would often think about care we would provide to cure patients and then thinking about palliative care at the end of life. But what we actually discovered as a result of the hospice movement in the 60s and 70s was that many of the concerns that patients were experiencing at the end of life, such as symptom problems, mental health issues, decision-making issues, were actually being experienced far earlier than the end of life. And there were many opportunities to address some of these issues, even at the point that a person gets diagnosed with their illness. And so now the viewpoint has really shifted to thinking about not just palliative care in the traditional sense when it's offered at the end of life, but thinking about palliative care and aspects of delivering palliative care that can be initiated even at the time of diagnosis and continued and fostered throughout a person's illness. So a question that many palliative care teams get asked is, what do palliative care teams actually do? And I thought it was helpful to look at these consensus guidelines that were created by the palliative care societies in the United States. And what they do is they break down palliative care into not just end-of-life care, which is what much of the public thinks, but also thinking about how do we address physical symptoms, psychological aspects of care, advanced care planning, issues that are happening as a result of a patient and family's social, cultural, spiritual, religious, and existential context. And so the goal of palliative care is to address all of these things as part of usual care. We traditionally think of palliative care as the specialty palliative care, and that's an important distinction to make. So there's specialty palliative care, which is this interdisciplinary team. In the United States now, 90% of hospitals have a specialty palliative care team. Not every health system has an outpatient team, but this is ideally a team of clinicians, either physician, nurse practitioner, social worker, chaplain, pharmacist, and many other people whose goal it is to provide all the things on the leftmost part of the screen across all settings and with continuity and doing assessments comprehensively. Another aspect that's a term that's emerged is this idea of primary palliative care, which is thinking about the current care team you have, like an oncologist, a hepatologist, and surgeon, and how they could start to deliver aspects of palliative care. And you might be familiar with this because, particularly if we're dealing with the situation when you're in a rural setting or setting where you don't have a lot of medical care or access to doctors, the team that you have often has to take on the role of addressing all of those things on the left. So what this kind of terminology is getting at is that, whereas in some contexts, it's a whole team of people taking care of a patient, in other contexts, it's one person, we should believe that people with serious illnesses deserve all the attention to the things on the left side of the screen. I just also want to highlight the fact that the guidances internationally really do support the fact that addressing all of these things, aspects of palliative care, does improve care and overall outcomes for patients with many serious illnesses. I'm going to go through a few research studies that I think might highlight some of the impact that palliative care has had in other specialties. I'm going to try my best to make it easy to understand and really highlight the big points. So this was the big trial that was done over 10 years ago now in patients with metastatic lung cancer, in which patients received either palliative care or no care for a few months. And this study, again, which was first of its kind, showed that there was a dramatic improvement in quality of life scores at the end of 12 weeks, which are shown by those numbers called the FACT-L score, the LCS score, and the TOI score. In addition to having significant improvements of quality of life when patients received early palliative care at the time of diagnosis, there were lower rates of depression at 12 weeks as well, which is an important outcome. But perhaps the most surprising outcome from this study was the fact that patients who were receiving palliative care compared to those that did not receive early palliative care actually on average lived greater than 2 months than the people who didn't receive palliative care. And in fact, the people who received palliative care were less likely to receive aggressive care at the end of life. So what this was building the narrative for, which I think, again, is an important part of addressing some of the misperceptions we have about palliative care, was that in this case, in this population, early palliative care actually did not lower the patient's life expectancy. It didn't lead to an early death. And it was associated with many important outcomes that patients and families thought were important, like improving quality of life and making sure that the patients didn't get aggressive care at the end of life. So I think this trial really put early palliative care on the spot for the individuals that are being treated in the trial, which were patients with a form of lung cancer. And what they did was they actually did, this team cleverly did an analysis of all of the different visits that the early palliative care team had with the patients and their families, and tried to understand, well, what was actually happening during these discussions? What we call it is what's in the syringe when it comes to palliative care. And, what they were surprised to find was that early in the visits, all that the palliative care teams were doing was really establishing rapport, talking to patients about symptoms and their coping mechanisms, making sure that they understand their illness and understand and are prepared for future decisions. There really wasn't too much discussion about things like hospice, about things like whether they would want a feeding tube or dialysis. These were really not part of the discussions. And I think that this addresses a big misperception that a lot of people have, including clinicians, that they often worry that if a patient sees a specialty palliative care team, that they're going to start to talk about death and dying and hospice. And that's often not the case if they're done early. It's really more focused on other aspects of the care. But yet, yes, when a patient gets more and more sick, you can see that does shift a little bit, but still is very much, these conversations are still very much featuring symptoms and coping. And there start to become more discussions about hospice as the patients progress and go towards their later visits. I'm excited to share that there is actually now some data, very small data, but still some data showing some improvements with regards to palliative care, with regards to HCC for patients receiving and not receiving palliative care. So this was a small trial that was published last year that looked at 26 patients who received UC, which is usual care, and 26 patients who received palliative care, and looking at outcomes at the end of 3 months. And this small trial did actually find that patients' global quality of life did have some improvement with the palliative care arm, which is measured by a quality of life measure called FACT-HEP. And when they did symptom assessments on patients, they found that many symptoms were actually significantly improved, including itching, appetite, sleep, muscle issues, fatigue, and pain. So even in this small study that lasted 3 months, they were able to find significant benefits for patients who received palliative care in the outpatient setting. Most of these patients also had ranged in many different forms of HCC, not just stage C, but also stage A, stage B, and stage B as well. Another study that I'd like to just briefly highlight is understanding that palliative care has actually had some benefits for people who are also being hospitalized. This is a study that was conducted by an investigator at Mount Sinai that looked at all of the different palliative care consultations that happened at Mount Sinai over a specific period, and understanding what were the effects of palliative care consultation. What they found was that patients were way less likely to get readmitted to the hospital when they received a palliative care consult, which was an important finding. And what they also found was that there were certain types of patients that were more likely to receive palliative care. People who reported high pain scores or had a high MELD sodium score or received sorafenib, which is an indicator of advanced HCC, were more likely to receive palliative care. But those who were thinking about or had received a liver transplant or were operating under a primary surgery service were less likely to receive palliative care. So I think this study was very important in showing a benefit of palliative care, but also showing some of the triggers that clinicians can sometimes use to consult palliative care, which may be something we can improve on. So I hope I shared with you in the last few minutes just how far we are, I think, from improving the lives of patients and their families when it comes to quality of life, caregiver burden, and end-of-life care, and then also sharing with you some of the positive aspects that palliative care integration can have. What I would like to do in the next few minutes is talk about how we realistically can integrate palliative care into practice. And I think this is something we can all learn from, even as patients and families, when you're thinking about the types of teams treating your patients and what types of barriers you might need to overcome. So the hesitations that often affect clinicians calling palliative care in practice tend to be the following. The first is that there often may not be as high quality studies that show the benefit of palliative care in liver cancer, although there are many studies that show the benefit of palliative care in other serious illnesses. So that can be a barrier to some clinicians who want to ensure that palliative care is delivered to patients with HCC. We know that part of the problem in having trials in general might be that clinicians may not want to enroll their patients in a study. So this sort of ends up becoming like a constant feedback problem, right? Is if you're not enrolling people in the studies that are going to show a benefit, that can be a continuous issue. The second issue could be that there just are a lot of cultural barriers or insurance barriers to palliative care integration. And I think these are things that we can work on culturally as clinicians, but also be thinking about ways that we can use policy as a lever potentially for improving care. However, there are a lot of perceived benefits too that are important to highlight to everyone when it comes to thinking about integration of palliative care in HCC practice. Multiple clinical guidelines support the integration of palliative care for patients with HCC, including those from the American Society of Clinical Oncology, from the American Gastroenterologic Association, from AASLD, which is the American Association for the Study of Liver Disease. We also know that that getting a palliative care consult might actually create data that teams, let's say multidisciplinary HCC teams, didn't have for decision making. As I mentioned before, many teams are focused on whether the tumor is growing or whether the patient might live or die, but they're not often getting information about a patient's quality of life, what the burden of their care, the burden that their caregivers are experiencing, their own symptom burden. Palliative care teams, especially palliative care teams, often use elicit that type of information. And if palliative care teams were more integrated in the liver cancer teams, they might be able to feed that information to the HCC teams when it comes to making really tough decisions where there's not always a right or a wrong answer. I like to call these gray zones. This is a really great paper that looked at strategies for considering palliative care at different stages that HCC patients are in when it comes to their disease. As you know, we often stage patients with HCC using the Barcelona classification, which can range from stage 0 to A to stage D. And in the second column, I show some of the types of treatment options we often offer to patients, their families, when it comes to treating their cancer. I also indicate that some of the physical symptoms that are experienced by their patients, depending on the stage of their tumor, might be quite different depending on where their tumor is, as well as the types of symptoms that they might experience as a result of the treatment that they're getting. So where I highlight on the right some considerations we can think about for integrating specialty palliative care teams, which is, thinking about ways that we can control physical symptoms better, educating patients about disease and doing advanced care planning early if they have early stages of cancer. When they have later stages of cancer, we might have to increase how much support we give caregivers, as well as patients for their psychosocial care and their spiritual care. They might need more assistance with some of these really difficult decisions they have to make. And when it comes to the latest stage, stage D, they might need more support when it comes to high impact symptoms, end of life care, and then supporting patients and their families through bereavement if the patient dies. So I do think that there are opportunities to integrate specialty palliative care teams across many different types, many different aspects of the patient's illness trajectory. I think this might come up, many times, but I did want to highlight some really great resources that are available to patients, families, and clinician teams who are really interested in integrating palliative care in their practices or in their family members' care. So there are actual clinical guidance documents from some of the societies I mentioned that I think are really important to bring to the table. Not just clinicians that should be doing that with themselves, but these are reference documents that state that best practices should be in integrating palliative care for these patients. I often talk to a lot of clinicians about ways that we can be better in terms of upskilling ourselves for many difficult conversations we have with family members. We know that patients, that often doctors in particular, but clinicians may not be the best at delivering serious news or discussing prognosis with patients and their families and just giving a straight answer. And some of these skills are teachable and learnable. And so I often talk about some of these programs that I've gone through that have helped me with my communication skills. And there are some papers that I've written along with my co-authors and colleagues that can be used by clinicians on how to frame some of these conversations. I think one of the best resources that I know of for educating patients and caregivers about palliative care is actually cirrhosiscare.ca, which is from Canada. This actually has a lot of resources on symptom management and very easy to understand graphics. Dr. Punita Tandon is the genius behind this amazing site, and I use it quite a bit when it comes to counseling families. They have very easy to understand videos. So, whereas I never point and say that there's only one resource for all of these things, I've certainly found an important space that this is serving, and encourage people to utilize some of these resources for patients and caregivers, in particular the cirrhosiscare.ca website. So I want to go back and close with this case and try to illustrate the outcome that I had as a clinician for this patient when he was being seen. So I referred this patient to specialty palliative care, the one patient who had decompensated cirrhosis and multiple liver cancers. And this team was able to provide support for advanced care planning. They provided some resources that the VA has for caregivers, as well as helped facilitate completion of FMLA paperwork for the patient's wife. And they also recommended starting cognitive behavioral therapy for anxiety. For this patient, we actually did elect to do chemoembolization twice, but unfortunately the tumor progressed and his liver function actually got worse. And this actually led to him getting upstaged to stage D, meaning that there are really no curative treatments that are available anymore, and chemotherapy would even be risky. And certainly transplant was out of the question. And so that this left no disease-directed treatments for him that were available. And at that point, we did end up discussing hospice with the palliative care team. We still discussed whether the patient wanted to get endoscopies because we still didn't want them to necessarily have complications like a variceal bleed, bleeding from their upper gastrointestinal tract, and still getting those procedures were still consistent with his goals of care. And then we talked about symptom control for his ascites, difficulty breathing, and cramps. And so what we were doing was that we were not abandoning his care. We were just changing and shifting the goals and thinking about different outcomes, understanding that transplant and some of these curative treatments were not an option. And I think we don't do that often enough for patients and their families, is helping them through some of these difficult decisions and then helping them refocus goals on things that are achievable. So in summary, I wanted to highlight the main findings from this talk. Wanted to first drive home the point that palliative care is an approach for caring for individuals with serious illness and their families, and it can be offered at any stage of serious illness, not just the end of HCC. There's really good evidence for its role in many different illnesses, particularly advanced cancer. And we know that it improves symptom management. There's some preliminary evidence that it improves symptom management and a reduction in readmissions for patients with HCC. We know, and we've talked about, significant gaps in multiple dimensions of care for patients with HCC. And we also talked about some of the barriers that exist from a cultural standpoint and potentially insurance standpoint. But I think that there are opportunities to overcome these barriers, and particularly opportunities for educating clinicians, addressing misperceptions, having a very clear role for palliative care teams on clinical teams, using them for gray zone cases. And I also think there's a significant opportunity for clinicians to improve their primary palliative care skills. And I think as a patient and family member or caregiver, it's helpful to be familiar with some of the literature that is currently there, as well as some of the resources that say that palliative care can be indicated for your loved one or yourself. And so I'd like to empower everyone to feel like this is something that they can take on and discuss with their treating teams. I always love ending with this specific phrase and quote from one of my favorite articles. It's talking about how challenging it is when we have situations where things are not going our way and how we want to still have hope. And it was written, this whole piece was written in JAMA, Journal of American Medical Association. And I really love this specific part of the paper. So I'll just go ahead and read it, which says, rather than being concerned that hope is either so fragile that it can be lost or so powerful that it can overwhelm decision-making, clinicians should remember that hope is protective, if not necessary for managing serious illness. Hope is fluid, expandable, and persistent. Holding complex, flexible, and diverse hopes enables patients to believe in the unlikely while simultaneously accepting the inevitable. The role of clinicians is to support both. So I think what this quote means to me is that I think it's our job as clinicians to feel that we're giving hope to patients no matter what is happening in front of them. So it's important for us to guide them in a direction, whether that's a positive, that's an outcome that we want or an outcome that we didn't want. Thank you so much for your time. I really wanted to particularly thank GLI for the opportunity to be discussing this topic, which I know is very sensitive to patients and families, but again, really appreciate everything that you guys do.
Dr. Patel, thank you. That presentation was wonderful. I haven't read that quote or seen that quote before at the end, but I love that on just reminding us all to hold the space for both. And it's not only singularly about hope, but thank you. So important. And I appreciate all of the passion that you bring, not only to hepatology, but to palliative care. I wanted to spend a few more minutes, if you don't mind, diving into a couple of questions. Palliative care, this is a space that's important to Global Liver Institute. This is an area that we obviously want to dive in the coming years and the coming campaigns. One of the things, too, that I love is I think upstream is you had mentioned rural access and palliative care rural. I think that's so important as we're starting to expand the outlook and really looking at patient and family-centered care, what that means to our rural communities. More to come there, but thank you. You have my wheels spinning and I really love all of this. My first question, you being based in LA, you obviously are exposed to a diverse patient population from ethnic backgrounds, also the socioeconomic status. What barriers to palliative care have been revealed from serving a patient population with such a multitude of background? And what do you think doctors should do to address the disparities for palliative care access?
Yeah, I think that's a great question. And, I think that, like I mentioned, like in palliative care is dealing with a lot of the quality of life issues, caregiver burden issues, and often later on deals with end of life care and hospice issues. And I think there is a specific gap that in terms of different race, ethnicities, geographies, and different people from multiple backgrounds receiving different care. I think the foundational aspect where I see big differences is illness understanding. And I find that often patients, when it comes down to where they're being treated or what types of resources they're being exposed to about just understanding the liver cancer can be so different. So I think that one opportunity that I've seen in just ensuring that people have similar care in general is making sure that they have a really good understanding of what HCC is and understanding that this is something what type of treatment options there are, which I think is part of the mission that GLI has. Now, once they do have a good understanding of what liver cancer is, addressing some of these other things like talking about advanced care planning, talking about dying and what to expect. There's a lot of differences that patients and their families might have about these topics depending on their culture and depending on what's important to them. But I find that a huge barrier is just the fact that often palliative care the terms may mean different things to different people. And it is the role of clinicians, as well as I think many organizations, to ensure that everyone's receiving a good, consistent definition, that they're understanding that it's not hospice, that they're understanding that it's not, that it's an extra layer of support when we think about what palliative care is. So, broadly putting it, I think that what we can work on is really addressing these misperceptions by like really listening to people about what they understand first and listening to their perspective and using that as an opportunity to engage them on what we view and what we think is what palliative care actually is.
Well, and I think that your case study that you started with and ended with, but those first initial slides, even you kind of dissecting, what do you think these questions mean and what are the underlining definitions that they're maybe getting at too? It is about really having quality listening and communication skills too. Thank you. GLI obviously values the importance of not only advocating for oneself, but also teaching how to advocate throughout the cancer journey, which helps the patient feel empowered to make decisions on their treatment plans. It can be challenging to find the sense of autonomy in a space, though, that feels unfamiliar. What do you suggest patients should do when expecting to receive palliative care so they're geared for success? And do you have suggestions for how healthcare practitioners can advocate for palliative care and guide these conversations? I know you mentioned that a little bit just now, but what are your thoughts?
Yeah, I think that's a really good question. I think where it starts for me is that I know that when patients are seeing doctors and clinicians in general, they have so many questions that they feel like they can't ask, or they feel like they don't know if that's the best use of the clinician's time, but they might be very important to them. Like I talked about, like taking time off work, or understanding how long you have to live. And I think these are conversations that take a lot of time, and they may not feel like that's something that they want to go through. And so I think it's important that if you're finding that there's a question that's taking too much time, it's probably really important to you. Mm-hmm. And that is something you should definitely think about bringing up. If you can't bring it up in the visits with your HCC doctors, it's important to know that you should feel empowered to bring those things up. And a specialty palliative care team would be a great option because their role is to really listen to those things. But aside from just those burning questions, knowing that this team is specialized to really address your physical symptoms, psychological issues, caregiver issues, spiritual issues, it just helps sometimes writing those things down on a piece of paper and keeping it close, which I'm sure many people do, and understanding that it's perfectly fine that if those things are important to you, you can make it known to your treating doctors, the HCC team, that listen, like it's important to me that, if I'm a person of faith, that I don't receive these types of things because of my faith, or I do receive these types of things, or this is this is the extent to which I'll go to, or it's really important for family members to be around. Like the types of things that come out of those conversations can be used to help with making decisions. And I want people to feel like those things are important to bring up, because if they're important to you, it's important that you're receiving care that's aligned with that. So I think all of this is just to say that your questions that you're worried about matter to someone, and it should matter to all of us, and you should feel empowered to bring it up to a palliative care team, as well as many of the other things that I talked about.
Thank you. I really appreciate that perspective a lot. Global Liver Institute, obviously serving a global audience and really pushing health equity and bringing that into conversation with liver disease. Palliative care is a service that's pretty unique just to a few countries: United States, Canada, and Australia, maybe New Zealand, not many more than that, due to my more limited knowledge. I'm so curious, as I think about moving forward in this space, serving HCC patients, how do you see palliative care expanding in other parts of the world in the future? And what are different cultural perspectives towards palliative care, how that implementation would work? Excuse me.
I think it's a really good point that you bring up, that, when we're talking about delivering palliative care, like the context matters, and cultures and different countries have so many different perspectives about this. I think one part the one trend that you've just mentioned about, like the fact that North America and Europe have maybe more integration of palliative care versus other places, it builds on this foundation that maybe there's more access to curative treatments at some of these countries versus some other countries may not have access to things like transplant and things like high quality HCC care. And that's always a priority for any country, is making sure at some point that they get access to those things. But it's also important to keep in mind that while many of these countries, they're facing challenges in getting access to the treatments, we still have patients who are suffering through their disease. We still have patients who are having uncontrolled pain, caregiver issues, mental health issues about decision making. So in my mind, there's a high opportunity to discuss palliative care issues, particularly for countries that don't have access to some of these curative treatments. But the barriers that come with implementing palliative care are similar to the ones we discussed, that sometimes palliative care means something completely different to people when you say those words. It means hospice. It means we're giving up on you. Mm-hmm. And I think if we come to a better unity and middle point of saying, like, no, we're not giving up on you. We're not abandoning you. We're taking care of you, and we're addressing the things we can address. And even addressing symptoms and your psychological and caregiver issues are important. Even if we can't get you to a transplant, we can't get you to cure. So I like to reframe in thinking that, we change the goals a little bit and address what we can address. And I think there is a value of shifting the conversation and making sure that patients understand palliative care from that context.
Thank you so much. And truly today, this conversation means a lot to me. And I know it's also a meaningful conversation for our patient and caregiver community, along with just supporting our clinicians and hepatologists into understanding more and really advocating for their patients. So thank you for your continued support and commitment to our liver community and to our palliative care community. And we are truly thankful to partner and work alongside you. For more information, for all of you who have tuned in today and continue to support the October for Liver campaign and Global Liver Institute, please visit our website at globalliver.org. Also, please visit our resource hub for all things cancer resources and research at livercentral.org. Have a wonderful October. Happy October is for livers. Thanks again, Dr. Patel.
Thank you.